Welcome back to Zabardast Health. This video today is actually going to be a capture of a webinar which discusses an introduction to and the ABCs of irritable bowel disease. Now, your lecturer today is actually an internal medicine specialist who has seen over hundreds of irritable bowel disease cases. The lecture today is going to talk you through the ABCs of the disease state, as well as go through a case study, as well as a variety of different examples of how this case may present. Without further ado, here is the lecture.
Today, we will be discussing about an uncommon disease in our country, which I believe is underdiagnosed. It is a very complicated disease, both in diagnosis and in management. As most of our audience consists primarily of generalists, internists, and non-gastroenterologists, I will try to make it simple, teaching you the basics of inflammatory bowel disease, or IBD. In this short period, over the next 45 minutes, we will try to learn the basics, the ABCs of IBD. I have no disclosures. So let us go to our learning objectives. First, is to recognize the clinical scenario when to consider inflammatory bowel disease in a primary care or non-gastroenterology clinical setting. Second learning objective is to get a general overview of the two types of IBD, namely ulcerative colitis, Crohn's disease, in their clinical presentation, diagnosis, and management. The disease IBD made it to the headlines last week when Japan's Prime Minister Shinzo Abe resigned from his position after surviving political scandals, plummeting approval ratings, only to fall to his disease, which was later revealed to be ulcerative colitis, which is a subtype of IBD. Ulcerative colitis has affected the Prime Minister's health over the last 15 years, so you could see it is a chronic condition. Okay, this would be the lecture outline for today. First, we will have a case presentation to be a springboard for our lecture. Then we will define inflammatory bowel disease. We will discuss the epidemiology of inflammatory bowel disease, its pathogenesis. Then we will go over the clinical presentation and diagnosis of ulcerative colitis. Then we will go over Crohn's disease, its clinical presentation and diagnosis, and then we will go to treatment of inflammatory bowel disease in general, and then I will give you some take-home messages. So let's start with the case presentation. We have a 26-year-old Filipino thin male with 1-year history of intermittent epigastric and lower abdominal pain, occasionally associated with meals and not relieved by bowel movements. He would have periods of diarrhea with some blood that would occur for several days, which would resolve on its own. He would feel better, and then symptoms would recur again. He had no nausea and vomiting, did not describe any fevers, but he thought he had difficulty gaining weight. He denies any cough or pulmonary symptoms, and in one of his labs, he was noted to be mildly anemic. Due to his persistent symptoms, he was seen by an internist who then referred him to a gastroenterologist. He underwent both an upper endoscopy and a lower endoscopy. The findings described were gastritis and colitis in the left colon and in the ileocecal area. The biopsies were thought by the pathologists as suggestive of tuberculosis of the colon. The patient was then treated with 6 months of anti-tuberculous treatment of quadruple therapy. So after that, the patient had initial improvement of the abdominal pain and rectal bleeding on anti-COX medicines. However, his symptoms of rectal bleeding and abdominal pain recurred. 1 year later, he went to see a different gastroenterologist because of persistent symptoms, who performed another colonoscopy that showed colitis in the left colon segment, and there was a note of a nodular mass affecting the ileocecal area with luminal narrowing of 5 millimeters. The patient was then referred to the surgical service, and he underwent right hemicolectomy. The surgical specimen showed transmural inflammation, no malignancy, negative for caseating granulomas, and negative for gene expert as a test for tuberculosis. Crohn's disease was strongly considered, and the patient was referred to the colorectal clinic of the medical city. So that is our patient. So what is important in this case presentation is we need to get the important historical details from the patient. I believe clinical history usually gives us the clues for the right diagnosis. The duration of the diarrhea, the abdominal pain, and other gastrointestinal symptoms are very important. With the duration, you can classify whether this is acute versus chronic. And if the duration is acute, usually we consider acute as within 2 weeks. We usually consider infectious causes unless proven otherwise. So this is why a lot of our physicians usually strongly consider amoebiasis and other infectious colitis as the cause of acute bleeding or acute bloody diarrhea. First, you need also to define whether the bowel movements are bloody or non-bloody, because the presence of blood or rectal bleeding suggests an invasive process. Systemic symptoms are also important to elicit because the presence of fever, anemia, or malnutrition can suggest some chronic inflammatory process. You also need to find out as far as the risk factors or exposures, whether the patient is immunocompromised, like HIV positive, if the patient has taken antibiotics in the last 2 to 3 months, or the patient had any form of radiation. Age is also important because some diseases occur in certain age groups as compared to others. Okay, so this is what a colitis look like on a colonoscopy. You could see there are ulcerations and exudates, and the colonic mucosa appeared edematous. So for a gastroenterologist, just this picture does not really give us a diagnosis. We still have to go back to the clinical history and try to elicit all these important clues from the patient. So it could still be infectious, and as we discussed earlier, you need to consider whether it's acute or chronic, and the more common organisms would be under the categories parasites, like amoebiasis, Entamoeba histolytica, certain bacteria like Salmonella, Shigella, Campylobacter, Yersinia, E. coli 0157H7, Mycobacterium like tuberculosis, and viruses like cytomegalovirus. This could also be inflammatory bowel disease. That is the topic of our lecture today. This can also present from ischemia, ischemic colitis. Drugs can also cause colitis. And examples of drugs would be like non-steroidal agents, the NSAIDs, and antibiotic-induced, especially if the patient took antibiotics and developed pseudomembranous colitis. It can also look like this. Radiation colitis can also show this picture, as well as other rare causes of colitis. Okay. The other thing we need to also remember is we need to differentiate IBD, which is inflammatory bowel disease, from IBS, which is irritable bowel syndrome. Since we will be discussing IBD later extensively, let me just give you an idea that IBS is a very benign condition. Patients usually have chronic recurrent complaints of pain and change in bowel movements, but usually these are non-progressive. All the lab tests, all the exams would be normal. So it is what we consider as a functional GI disorder. So just to remember, IBD, D for disease colon, IBS, S for symptoms, so that you won't be confused with the acronyms. Okay, now let's go to the lecture proper, which is on inflammatory bowel disease. Okay, so when we say inflammatory bowel disease, it refers to two chronic, idiopathic inflammatory disorders, ulcerative colitis and Crohn's disease. It is defined by a constellation of characteristic, clinical, endoscopic, and histologic features critical for the diagnosis of IBD. So that's why it makes the diagnosis a little bit difficult, because there is no single individual finding that is absolutely diagnostic. And remember, inflammatory bowel disease is a chronic condition, and it is characterized by relapsing and remitting episodes of inflammation. So they could be sick in certain periods of time, and they could be well during certain periods of time. Okay, so how about ulcerative colitis? So the hallmark of ulcerative colitis are it is limited exclusively to the colon, and the inflammatory process is confined to the mucosal layer. There are 5 layers in the colon, and the mucosa is the innermost layer, and it is a continuous ulcerative process. So if you have ulcerative colitis, it starts and involves the rectum all the time. And then it may extend and involve the more proximal portions of the colon in a continuous fashion. So these are the terms that you probably should know: ulcerative proctitis, ulcerative proctosigmoiditis, left-sided colitis, and pancolitis. So in this particular pattern, you only have involvement of the rectum, so you call this ulcerative proctitis. Then here, it involves the rectum and the sigmoid colon. You call this ulcerative proctosigmoiditis. And then it involves the left colon up to the splenic flexure. We call this distal colitis. And then we don't use extensive colitis anymore. Pancolitis is involvement of the entire colon, both the left side and the right side of the colon. How about Crohn's disease? Crohn's disease involves ulcerations, and the ulcerations are usually transmural. So when we mean transmural, it involves all the 5 layers of the colonic wall. It is also characterized by skip lesions. When we say skip lesions, there are areas that are diseased and there are areas that are normal. So it is not continuous, and it may occur anywhere in the GI tract, from the mouth all the way to the anus. And the most commonly involved parts uh, in the Crohn's disease are the distal ileum and the proximal colon. This transmural inflammatory nature of Crohn's disease may lead to fibrosis, strictures, and obstruction. It can also lead to fistula formation. Although it seems like you could easily distinguish ulcerative colitis from Crohn's disease, there are 10% of patients with IBD who have indeterminate colitis. Doctors have difficulty establishing whether this is UC or Crohn's. And because of this, the characteristics of both disease entities can overlap despite having distinct pathological and clinical characteristics. So here are the patterns for Crohn's disease. It may just involve the small intestine. It could involve the ileocecal area, and you have this patchy inflammation, or it could just be involved the colon. This pattern is around 35%, in which only small intestine is involved. The ileocolonic area is the most common pattern, contributing to around 45%, and then the isolated colonic involvement is 20% of Crohn's. Okay. How common and what is the epidemiology of inflammatory bowel disease? Inflammatory bowel disease occurs worldwide, but the highest is among European and Anglo-Saxon origin in North America, United Kingdom, and Northern Europe. So a lot of this Crohn's disease you see a lot among the Scandinavians, among the Canadians, and certain Americans. And even among Caucasians, some have a higher risk and have more common IBD compared to others. And this is especially true for Ashkenazi Jews. These are certain ethnic groups originally from Israel, and they have 2 to 4 times increased risk compared to whites who are non-Jewish. The incidence of IBD is also much lower in South America, Asia, and Africa. However, in the last decades in Asia, there has been an increase in incidence in developed countries, where there was a note that the rate of IBD rises with urbanization. There are now a lot of patients with IBD in Japan, like Prime Minister Abe, in Singapore, Hong Kong, and China. Okay? Both sexes are equally affected. And in general, ulcerative colitis remains slightly more prevalent than Crohn's disease. So how about in the Philippines? I borrowed this slide from Dr. Jose Soliano. He is a very prominent gastroenterologist, and he established the IBD Club. This is to facilitate learning and diagnosis among the gastroenterologists. This was established in year 2000. And this data only involves in 2012, and Dr. Soliano told me that there would be an update soon. But as you could see, from 2000, 2012, there has been an increase in the diagnosis of IBD. And part of the reason is increased awareness among gastroenterologists. The blue ones, the blue bars are ulcerative colitis, and the red bars are Crohn's disease. So as you can see in the Philippines, more ulcerative colitis are diagnosed than Crohn's disease. Okay. Regarding the age and incidence of IBD, the age of onset for many patients is between the age 15 to 30 years old, as you could see here in the graph. And IBD, though, can present at any age. And some studies suggest that there could be a second peak much later in life, between 50 to 60. And these are probably patients who probably had mild disease during their childhood, and only presented during a much later in life. What are the risk factors for IBD? First, we talk about family history. Obviously, if you have a parent or a brother or a sister who has UC or Crohn's disease, you have the 4 to 20 times increased risk because IBD is most likely genetic. Number two, as we discussed, Caucasians and Ashkenazi Jews are at the highest risk to develop IBD. Smoking is a risk factor for Crohn's disease. The use of non-steroidal anti-inflammatory drugs or NSAIDs have also been implicated as a risk factor for IBD. And a possible explanation is that cyclooxygenase-mediated disruption of the intestinal epithelial barrier can affect the interaction between the gut microbiome and the immune cells. Some patients who eventually develop IBD also reported that they have a prior episode of an acute severe gastroenteritis. And there was some prevalent study that also showed that appendectomy might be an increased risk factor in Crohn's disease. And we thought the explanation is most likely since Crohn's disease affects the ileocecal area, there may have been a false diagnosis earlier, thinking the patient developed appendicitis and underwent appendectomy when the patient actually had Crohn's disease to begin with. And a question of a diet high in fat may also be a risk factor for IBD. Okay. So let us discuss briefly. I don't want to be too detailed here because it is very complicated as far as the pathogenesis of IBD. It still remains poorly understood. However, there are three major components of the pathway which contribute to the activation of the disease. Number one, there is a genetic predisposition in that particular individual. Number two, there is dysregulation of the immune system. And then there is an environmental intestinal antigen that triggers all this cascade of reactions. Okay, so starting first in the patient. The patient has an abnormal state of defective intestinal mucosal barrier, allowing easier permeability to normal luminal bacterial antigens. So the lining of the intestine of the patient has a lot of defects. So it is like a leaky gut. So bacteria can easily pass through the wall. And then you have an aberrant host immune response. So your innate immune system should easily clear the microbial antigens. However, there is a problem in clearing these persistent microbial antigens. And there's also a loss of immune tolerance to normal ubiquitous luminal antigens. Because of this interaction, there is an overactive and sustained immune response against the trigger pathogen. So your immune system attacks the intestinal cells, causing this colitis or enteritis. And with this inflammation, there is the release of several inflammatory mediators, which include cytokines, interleukins, and tumor necrosis factor. So this is just an illustration that the mucosal wall of the colon or small intestine is defective. So there is easy access of the bacteria going into the inside of the colonic wall, where they are met by the antigen-presenting cell. And you have the macrophages and the helper cells. And this interaction and cascade show and will release a lot of mediators like tumor necrosis factor and interleukin 12 and 23. Okay, this seems to be like a very busy diagram, but I just want to point out the differences in a normal colon wall and a patient with IBD. Okay, so here in a patient who do have IBD, there is a loss of the mucus protective layer. So this is in a normal colon or intestine. This is the normal mucus layer. Here, you lose the mucus layer, and you have spaces now between the cells, so the bacteria could easily go in when normally in an intact, healthy patient, the bacteria stays outside. Okay, so once the bacteria goes in, it invites all these macrophages and helper cells, and then releasing all these mediators, which include tumor necrosis factor, TNF, interleukins 12 and 23, and a lot more. And then once you go lower here, you have this endothelial blood vessel. Okay, this is a blood vessel, and when there's inflammation here, it recruits a lot of white cells, and because of the inflammatory mediators that are produced, a lot of the white cells are actually recruited here, and this results in a very congested colonic or small intestinal wall compared to a normal colon wall. Okay, so a little bit complex diagram, but I just want to point out the differences between a normal and wall of the GI tract in a person with IBD. Okay, so let's go first to ulcerative colitis. What are the clinical presentations of UC? Number one, most of them will present with bloody diarrhea, which is frequent and usually small in volume, and the frequency range between 3 bowel movements a day to 10 bowel movements per day. The patient can have colicky abdominal pain. They could have urgency because the rectum is involved. They need to go to the bathroom immediately. Tenesmus is the symptom that is usually present in colitis, in which the patient feels incomplete evacuation even after a bowel movement. And some patients could even develop incontinence. One thing you need to remember about UC is the onset of symptoms is usually gradual. So it is not something like food poisoning or acute gastroenteritis that the patient is healthy on one day and the following day the patient is sick. So here the onset of symptoms is usually gradual. The symptoms are progressive over several weeks. The systemic symptoms like fever, fatigue, and weight loss can occur in severe cases. Okay. Talking about the natural history of ulcerative colitis, these attacks of bloody diarrhea can last for weeks to even months, and these are what you call flares. Even with treatment, the course of ulcerative colitis consists of intermittent exacerbations or flares, alternating with long periods of complete symptomatic remission. So your goal in a patient with ulcerative colitis is to keep them on remission. However, a small percentage of patients have chronic symptoms and are unable to achieve complete remission. So, in diagnosing ulcerative colitis, as we discussed before, you need to have clinical clues in the history because you need to make sure this is ulcerative colitis, because ulcerative colitis is a diagnosis by exclusion. You do not think first of ulcerative colitis in our setting, but you want to make sure that you have ruled out everything that is the most likely cause of the colitis. So you ask for risk factors for the other causes of colitis, like radiation, antibiotic use, and amoebiasis is a very important differential diagnosis for our clinicians, since a lot of the our patients who turn out to have IBD were initially diagnosed to have amoebiasis, bacterial infections, recent intake of antibiotic use, which is from Clostridium difficile, used to be the old name before. Now it is called Clostridioides difficile infection, which is from the intake of antibiotics that kills the good bacteria and leaves the bad bacteria to proliferate. We discussed you need to ask about nonsteroidals and other medications that could cause diarrhea. And also big in our setting is we need to find out, are there any clinical features to suspect tuberculosis, since this is very endemic in our country. We need to also ask for risk factors for sexually transmitted diseases like Neisseria gonorrhea and herpes simplex, since this can be associated with proctitis, especially in men who have sex with men. Immunocompromised status is also important because cytomegalovirus can also mimic ulcerative colitis. And if you have a patient with severe heart problems, they could develop colonic ischemia and can present with ischemic colitis. And as we mentioned, a history of radiation should suggest that this could be radiation colitis. Okay, so how do we classify and define the severity of ulcerative colitis? So this is a modification from the Montreal classification of ulcerative colitis. It can be defined as either mild, moderate, or severe. And this is based on the certain criteria: the number of bowel movements, the presence of blood, the presence of abdominal pain, and then the presence of systemic toxicity like fever and anemia. Patients with mild ulcerative colitis have 4 or fewer bowel movements. There may be blood. The pain is usually very mild, and usually it's just cramps. And there's no fever or signs of toxicity. In moderate ulcerative colitis, you have more than 4 bowel movements. They could be bloody, and they could have mild abdominal pain, and they could have signs of toxicity like low-grade fever and mild anemia. And then for severe ulcerative colitis, there's usually more than 6 bowel movements. They're usually bloody. They have moderate abdominal pain, and they are sick. You know, they have fever, they have abdominal distension, and this patient may need to be in the ICU. Ulcerative colitis is a progressive disease because some patients may just present with proctitis, like this one, but after a few years, it may progress to pancolitis. So in this Swiss cohort study, they were able to follow patients over 9 years, and they noticed that around 15% of UC patients experience proximal disease extension over a span of 9 years. Okay, so this is true for both ulcerative colitis and Crohn's disease. Patients with IBD can present with extraintestinal manifestations, and these are manifestations outside the digestive tract. And initially, only around 10% of patients will have EIM, extraintestinal manifestations. However, around a quarter of these patients will have extraintestinal manifestations in their lifetime. So this can be just arthritis, and usually the joints that are involved are the large joints and the weight-bearing joints like the knees. Some patients, especially males, can develop ankylosing spondylitis, which is the fusion of vertebral bodies in the lower vertebral area, causing what we call as a bamboo spine. Some patients may also have eye involvement, like uveitis and episcleritis. Then the interesting ones, erythema nodosum and pyoderma gangrenosum. These are dermatologic manifestations of IBD. Erythema nodosum is having developed tender erythematous nodules along the sheens. This can be found in both types of IBD. And you could have this really gross skin ulcer called pyoderma gangrenosum. Okay, it could also affect the liver. In this particular case, the condition is primary sclerosing cholangitis, in which you have inflammation of the bile ducts resulting in stricturing and beading of the bile ducts. This by itself is a risk factor to develop cholangiocarcinoma, which is cancer of the bile ducts. And at the same time, in a person who has ulcerative colitis and primary sclerosing cholangitis, it increases the risk of colon cancer further. Okay, patients with IBD are also at high risk for arterial and venous thromboembolism. So how do we work up the patients with ulcerative colitis? Either when we're still trying to diagnose it first, or when they're having relapse. We could order the initial blood test, like a complete blood count, looking for signs of anemia or leukocytosis. And let's do a comprehensive metabolic panel, including tests for creatinine. Then you could order an erythrocyte sedimentation rate and the CRP, which are markers for inflammation. Usually when there is high activity of IBD, this ESR and CRP, they also go up. However, between the two, the CRP is a more sensitive test than ESR. Then you could measure albumin, which could determine the nutritional status of the patient, given the fact that this is a chronic inflammatory condition. For the first time you're trying to come up with a diagnosis of IBD, you really want to make sure it is not infectious. Remember, especially in our setting, if it's acute diarrhea, acute bloody diarrhea, you assume that it is infectious unless proven otherwise. However, if they become recurrent and they've been treated with antibiotics and the symptoms still keep coming back, then you need to think of non-infectious causes. So you need to send stool cultures to make sure there is no salmonella, no shigella, no campylobacter, no yersinia, no E. coli 0157H7. Send fecalysis to look for ova and parasites, specifically, especially in our setting, especially for our clinicians in the general clinics. Make sure it's not amoebiasis. Also rule out giardia. And then the fecal calprotectin and lactoferrin. These are actually also very important tests. They are like the ESR and CRP in the stool, and they usually represent neutrophil activity. So normally, if you have an elevated calprotectin or lactoferrin, the chance of having IBD is higher than IBS, because in IBS, you expect the patient to have normal blood and stool tests. There are also special tests, and unfortunately, these special tests are only available at St. Luke's Global. We have the p-ANCA and the ASCA, the anti-Saccharomyces cerevisiae antibody, and you can actually, the gastroenterologist can order this. The p-ANCA is more common in ulcerative colitis, while the ASCA is more common in Crohn's disease. However, this is not sensitive nor specific, so this would just be more to support your diagnosis rather than to establish diagnosis. And if you are suspecting proctitis from sexually transmitted disease, then you could do the STD test. Okay, so once you make a diagnosis and then you do labs, obviously the next step is to really send your patient to your friendly neighborhood gastroenterologist to perform colonoscopy, and some x-rays may be needed. Okay, so this is why you need a gastroenterologist to do a colonoscopy. So not just examination of the colon, but also take a look at the ileum, which is a common involvement in Crohn's disease. Okay, so this is a picture of the colon. This is a normal colon. It's smooth, shiny, and you could see that the blood vessels are very visible and normal. Here, you could find the ileocecal valve, which looks very healthy. And once you enter the colonoscope through that ileocecal valve, you reach the ileum, the terminal ileum. Okay, so knowing now what normal colon looks like, just by looking, even if you're not a gastroenterologist, definitely you will think that these are not normal findings. Here you have these ulcerations, which is, you can define here it with being irregular. You have exudates, you have erythema, they're very friable, and the blood vessels that you saw earlier in a normal colon are no longer found. Okay, here you have pseudopolyps. Okay, and pseudopolyps can actually progress to an extent like this, that practically the whole wall is full of pseudopolyps. Okay, so these are the other findings you see in ulcerative colitis. However, the problem is, as we said, IBD findings like this are not very specific. So CMV colitis could look like this. C. difficile colitis could look like this. TB colitis could look like this. So that's why clinical history and endoscopic findings are both important. So after endoscopy, then you need to take biopsies. Okay, when you take biopsies, you send it to your pathologist, and usually the reason why we send biopsies is to establish the chronicity of the inflammation and exclude other causes of colitis. So in ulcerative colitis, there's still no single finding that will clinch the diagnosis. You will see crypt abscesses, crypt branching, predominant lymphocytic infiltrates. However, all of these are non-specific and will not be enough to establish the diagnosis of UC. Okay, and how do you diagnose ulcerative colitis? So as we mentioned, it is a combination of all the tests that you do. From the history, you need to have chronic diarrhea, which is defined more than 4 weeks. The presence of active inflammation on colonoscopy, chronic changes on biopsy, and ruling out other causes of colitis. Remember, there are other causes of colitis. So you want to make sure that you rule them out. And then once you rule them out, then if it's really UC, then it's UC. Okay, so these are the Copenhagen criteria. So Copenhagen is the capital of Denmark, and it is very common in Denmark since it is in Scandinavia. And for them, all criteria must be present to diagnose UC. So the history of diarrhea, rectal bleeding, since it's relatively common in them, they use just more than 1 week, but usually for us, we want 4 weeks. Then you have the characteristic findings of ulcerative colitis, which is the continuous ulceration, vulnerability, and granulated mucosa, as well as histopathology that we just discussed, consisting of neutrophils within epithelial structures, crypt abscesses, and cryptitis. So there are also complications of developing ulcerative colitis. So as we told you, it is a progressive disease, and it may not improve. It could get worse, okay? So acute complications include bleeding. As you could see, there's ulcerations. You could have significant anemia from the bleeding. You could develop fulminant colitis. and toxic megacolon. So these are the severe types. And toxic megacolon is characterized by a dilated colon, and the patient really looks sick, febrile, leukocytosis, and they need to be in the ICU. And eventually, toxic megacolon, if not treated properly, can lead to perforation. How about chronic complications of ulcerative colitis? These are the strictures, and at the same time, once you have ulcerative colitis, because of the recurrent inflammation, you have high risk for colorectal cancer. Okay, so this is a picture of a benign stricture in ulcerative colitis. This is a barium animal, which shows the stricture here. And then this is a benign stricture. And this one has developed malignancy and is a malignant stricture. Okay, this graph just shows you that having ulcerative colitis over a prolonged period of time will increase the risk for colon cancer. Usually, if you have pancolitis, the risk increases around year 8 to 10 upon diagnosis. And if you have left-sided colitis, there is an increase of the cancer starting after 15 years. Okay, now let's go to Crohn's disease. So we talk about ulcerative colitis, now Crohn's disease. Patients with Crohn's disease can present with chronic pain and diarrhea. And sometimes their diarrhea is not as bloody, unlike in ulcerative colitis. They could have signs of inflammation, like fever. They can present with bowel obstruction. They could have abscesses and fistulas. So this is a flat plate of a patient presenting with bowel obstruction with Crohn's disease. As you could see, the small intestinal loops are dilated. Then this is most likely from the obstruction at the level of the ileocecal area. Okay, this is in contrast to ulcerative colitis. In Crohn's, there is transmural inflammation. So it involves all the 5 layers of the colonic wall. You also find skip lesions. Skip lesions is a pattern in which you have disease segments alternating with normal segments. So unlike ulcerative colitis, which is continuous starting from the rectum, here you see skip lesions. And the patterns can be inflammatory in nature. They could be stricturing. You could have fistulas from Crohn's and severe perianal disease. Crohn's disease is a heterogeneous inflammatory disorder that may affect different sites in the GI tract. And I think I discussed earlier that it could involve the mouth all the way to the anus. And it is usually characterized by a high rate of stricture formation and penetrating disease complications. Okay, this is what you see on endoscopy of Crohn's disease. Here, you find aphthous ulcers. These are similar to the mouth sores that we occasionally develop when our immunity is down. The difference here with ulcerative colitis is the surrounding mucosa looks relatively normal compared to the aphthous lesions. And this can progress to longitudinal ulcers. So this may look a little bit more like the ulcerative colitis now, in which you have longitudinal ulcers here. And sometimes there is a pattern that you could find in Crohn's disease. It's called cobblestoning. You see areas of ulceration and areas of elevated mucosa, and this is formed with the union of longitudinal ulcers and transverse ulcers producing islands of mucosa, producing this cobblestone in appearance. Okay, fistula. Fistula is an abnormal connection between 2 cavities that are lined by epithelial cells. So here you have a fistula from one part of the intestine going to another part. Here you have an enterocutaneous fistula, and then here you have perianal disease. Okay, what are the histologic findings in Crohn's disease? As we mentioned, it's usually transmural, and unlike in ulcerative colitis, you actually find granulomas. Okay, and these are usually the non-caseating type, and however, these granulomas are only found in less than 30% of the cases. However, if you find the granuloma, then it is most likely Crohn's disease. Okay. And the features that favor Crohn's over ulcerative colitis, we did mention this over the previous slides, chronic pain and diarrhea in the absence of gross bleeding, the presence of perianal disease, presence of fistulas, and on endoscopy, usually there is no rectal involvement. If it's small intestinal, then it's most likely Crohn's. And then you have skip lesions and you see granulomas on biopsy. The workup is also the same as far as working up the patient for ulcerative colitis. So basically trying to rule out the other causes of colitis or enteritis. Okay, so this is a picture, and this is the scenario in which a lot of the gastroenterologists are usually having a dilemma. It is to differentiate, can this be Crohn's disease or could this be tuberculosis of the digestive tract? Because both disease can present with abdominal pain, bowel obstruction, diarrhea, fever, anorexia, and weight loss. And they could also present with similar endoscopic findings. And both of them affect the ileocecal area. Okay, so just by looking, it would be hard to differentiate if this is Crohn's disease or this is gastrointestinal tuberculosis. So I made this table. This is just to kind of help differentiate Crohn's disease from intestinal tuberculosis. It is not really written in stone since some features are more common than others. So patients who have fever, night sweats, and they may have a pulmonary process, that's more intestinal tuberculosis. If patients have bloody diarrhea, that is more common in Crohn's disease. If they have perianal disease, that is more like Crohn's disease, although perianal disease can also occur in intestinal tuberculosis. Both extraintestinal manifestations can occur in both diseases. The longitudinal ulcers, the cobblestone, and the aphthous ulcers, they're usually found in Crohn's disease. The creep branching is also found more in Crohn's disease. Transverse fissures, more in Crohn's disease. And people with Crohn's tends to have a longer disease duration. And if you have the last three here, this will clinch the diagnosis for intestinal tuberculosis. If you find caseating granulomas in the biopsy, you have the positive acid-fast bacillus on smear or biopsy, or if you have necrotic lymph nodes on CT scan. However, you do not find this in majority of patients with gastrointestinal tuberculosis. So now let's go to the final section, which is the treatment of inflammatory bowel disease. And we're discussing both Crohn's and ulcerative colitis since we're treating them with similar medicines. Okay, you have the 5 aminosalicylates, that are the 5-ASA. You have the corticosteroids, which we have prednisone, budesonide. We have the immunomodulators and the biologics. Okay, so mesalamine or mesalazine or 5-ASA is the most commonly prescribed medicine here in the Philippines for IBD. In patients with IBD, there is a mucosal production of arachidonic acid metabolites like prostaglandins and leukotrienes. So what 5-ASA does is it decreases the inflammation by inhibiting the enzymes cyclooxygenase and lipooxygenase in the colon, which in turn blocks the production of prostaglandins and leukotrienes, inhibiting the bacterial peptide-induced neutrophil chemotaxis. And this medicine is active only intraluminally, so it is not absorbed. Mesalamine is available in tablets, enemas, foam, and suppositories. And if it's the oral drug, it is encapsulated in time-release microgranules or pH-sensitive resins because you want this medicine to be released in the area of the ileum and the colon. So if you have proctitis here, normally mesalamine suppository should be enough. Okay? If you have sigmoid colon involvement, then you could give rectal folds. If it goes all the way up to the splenic flexure, enemas would be great. However, if you have pancolitis, you need to give the oral form of mesalamine. And mesalamine is effective in inducing remission and maintaining remission in both UC and Crohn's disease. How about corticosteroids? Corticosteroids are used to control inflammation during acute flares if 5-ASA is not effective. It downregulates the inflammatory cytokines in IBD, and these are not used as maintenance medicines due to side effects. So they are used to put the patient in remission to treat a flare, but you do not put the steroids to maintain them on remission because of the side effects. The most common medicine is prednisone, and there's a newer medicine which is budesonide, which has a high first-pass liver metabolism. So it is more a topical medicine since it is not really systemically absorbed, but the problem is it is more expensive and is not as effective as prednisone. And usually it works better in Crohn's, but not in ulcerative colitis. How about immunoregulators or immunomodulators? These inhibit T cell function. So examples of this are mercaptopurine and azathioprine. The problem of giving these medicines is it requires 2 to 3 months to see the beneficial effects. So if you have a patient sick with colitis, they're having a flare, this is not the medicine to give. However, they are effective as long-term treatment since you could actually reduce the corticosteroid requirements and take them off steroids. However, there are a lot of side effects which include bone marrow suppression, hepatotoxicity, and pancreatitis. Okay, now we go to the last category of treatment, which is biologics, and you've seen this slide earlier. As you can see here, you have the interleukin 12 and 23 here, and you have the tumor necrosis factors. So these mediators are the targets of the biologic agents. Okay, the first group of biologic agents are the anti-tumor necrosis factor agents or antibodies to TNF. Okay, so infliximab, that's the first anti-TNF agent to come out, is a chimeric immunoglobulin G monoclonal anti-TNF alpha, which is given through intravenous infusion. Okay, there are other medicines like adalimumab, which is a recombinant human immunoglobulin, and this is given subcutaneous. And the two others are more like second line, golimumab and certolizumab. However, since they interfere with your immune system, the side effects are actually very significant. And this could include infection, sepsis, tuberculosis reactivation, worsening of hepatitis B, lymphoma, and hematologic toxicity. The other category for biologics is the anti-interleukin 12/23 antibody. And the medicine that is available is the ustekinumab, which is a human IL-12/23 antibody. And this medicine is given intravenously during induction phase, and maintenance will be given subcutaneous. The other medicine is the anti-integrin antibody. So, and that is vedolizumab or Entyvio. It is a humanized monoclonal antibody to alpha-4 beta-7 integrin, which is a mediator of gastrointestinal inflammation, resulting in the blocking of the entry of inflammation-stimulating lymphocytes. So let me just show you the picture here. Okay, so normally you have in inflammatory bowel disease, you have this T cell which is recruited from the blood vessel, and it does have this the alpha 4 B7 integrin, which connects with the gut homing T cell receptor. Okay, and this is the colonic mucosa. So what vedolizumab does is the antibody blocks and attaches to this receptor. So these lymphocytes does not connect anymore with the gut homing T cell, and you decreases the inflammation in the gut. So in a way, it is a very selective anti-inflammatory body in our digestive tract in IBD. Okay, you could also give adjunct therapy to patients who are having diarrhea. You could give loperamide. You could give probiotics, although the evidence in probiotics is not so strong. And antibiotics may be helpful in Crohn's disease, and usually the medicines used are metronidazole, ciprofloxacin, and rifaximin. So as far as treating patients with IBD, it's either a step-up therapy or top-down therapy. In step-up, you start with the most basic and non-toxic medicines going up. In top-down approach, you start with the biologics and work your way down. So you need to put the patient into induction first, and then you need to put them on maintenance medicine to maintain them in remission. Okay, if medicine does not work, then you don't have a choice, but you have to refer your patient to your colorectal surgeon in your institution. And these are the indications for surgery. First, you have toxicity and risk for perforation. If the patient's really having severe ulcerative colitis, they need to go to surgery and not responding to medicines. If the patient's having a life-threatening hemorrhage, if there's fistula, especially between intestinal segments, if they present with bowel obstruction, if there is suspected cancer or confirmed significant dysplasia, or if they're just not responding to medicines. Okay. I believe this is the most important slide for the entire lecture. So if you have to remember one slide, this is it. Okay. So this is just a recap of what we discussed so far. So hematochezia is more common in ulcerative colitis. If you have small bowel disease, it is Crohn's disease and not ulcerative colitis. If you have upper GI tract, it's Crohn's disease. Both extraintestinal manifestations can be found in both. And then if you have fistula or perianal disease, that is Crohn's disease. P-ANCA is more common in ulcerative colitis. ASCA is more common in Crohn's disease. When you have transmural inflammation on the biopsy, that is Crohn's disease. Granulomas are present in Crohn's disease, but only 25% will have granulomas. Skip lesions are present in Crohn's disease. So our take-home messages are the following. Number one, consider inflammatory bowel disease in the right clinical setting, especially in those patients with recurrent and chronic gastrointestinal symptoms in which you have already ruled out the more common causes of their colitis. Ulcerative colitis and Crohn's disease can be differentiated from each other in most clinical situations.